Here is a super clutch psych review of tricky disorders. These are some of the things that I always get confused in my head. We'll start off with somatic symptom disorder. This is going to be excessive anxiety and behaviors due to unexplained symptoms over 6 months that cause impairment. They are rarely reassured by negative findings in their health workup. These patients have real symptoms though. So for somatic symptom disorder, they actually have the symptoms. It would be stuff like excessive fatigue, headaches, lightheadedness, and GI upset. The treatment protocol for that is regular visits with the same provider. This provides reassurance for the patients. So you really want to have continuity of care for somatic symptom disorder. Next is illness anxiety disorder. These patients have literally no real symptoms, but they think they have the symptoms, i.e. the patient thinks they have a cancer, but they have zero proof of it and zero symptoms that indicate they would have it. Conversion disorder is neurologic symptoms that are incompatible with any kind of pathophysiology or anatomy that they have going on. Factitious disorder. This is falsifying symptoms or causing self-injury in the absence of obvious external rewards. This is contrasted with malingering, where the patient is clearly trying to obtain external rewards. So if they don't have a clear goal, you're going to go with factitious disorder. If they have a clear goal of what they're trying to get, you're going to go with malingering. Panic disorder. This is recurrent and unexpected panic attacks that can be described as chest pain, palpitations, shortness of breath, choking, dizziness, trembling, sweating, nausea, chills, etc. The treatment for panic disorder is going to be SSRI or SNRI plus or minus CBT. If it's an acute episode, however, you want to go with a benzodiazepine. Here's a test-taking tip. The way to differentiate panic disorder from somatic symptom disorder. Somatic symptom disorder will have persistent physical symptoms and not necessarily an acute presentation such as panic disorder. So if it's persistent, go with somatic symptom disorder. If it's intermittent, you'd want to go more with panic disorder. And here's a review of illness anxiety disorder versus adjustment disorder. Illness anxiety disorder is excessive concern about an undiagnosed medical disease for over 6 months. Adjustment disorder has an onset within 3 months of a specific stressor, such as a newly diagnosed medical condition. So if they just got told that they have cancer and a couple months later they have this feeling of anxiety and stress, instead of going with illness anxiety disorder, you want to go with adjustment disorder because they have an actual diagnosis of cancer. If it's an undiagnosed concern that they don't really have clear proof of, then you'd go with illness anxiety disorder. 24. Acute stress disorder. This will be over 72 hours, but less than 1 month. And so the treatment is trauma-focused brief CBT. You want to consider treatment for the patient's anxiety and insomnia. This can be impairing. And you want to monitor these patients for PTSD, which it would only be considered if it lasted over 1 month. Here's a test-taking tip. If the timeline is over 1 month since a trauma, you immediately cross off acute stress disorder, no matter how much the question sounds like it's pointing towards that. Remember, acute stress disorder is only less than 1 month, whereas PTSD would be over 1 month. 25. For smoking cessation. This is super high yield. Remember, it can often take over 3 months to actually improve outcomes for the patient, and that's important to discuss whenever you are counseling your patients. Varenicline is the most effective pharmacologic intervention, even more than bupropion and nicotine replacement therapy. However, varenicline can cause some weight gain, unlike nicotine replacement and bupropion. Combining it with nicotine replacement therapy is even more effective, even without any increased side effects. It has not been shown to have a negative impact on cardiovascular health or hypertension like previously thought. Bupropion can worsen hypertension though, but it is beneficial if there's concomitant depression. So if the patient has depression, you might want to go with bupropion instead. It's kind of killing 2 birds with 1 stone type of approach. Varenicline does not have a black box warning for suicide and depression anymore. This was redacted in 2016. So if you're studying a USMLE resource that says varenicline has a black box warning for suicide or depression, that resource is outdated. It is now considered the most effective pharmacologic intervention with a safe profile of side effects. When setting quit dates with your patient, you want to make sure that the date is within 2 to 4 weeks once they're ready to maintain motivation and decrease the patient second guessing themselves. So let's go through my algorithm. If the patient is not quite ready to quit, you can prescribe varenicline to facilitate the reduce to quit strategy. This has a twofold higher rate of durable abstinence. You want to bring up cessation respectfully at every single clinic visit with these patients. If they are ready to quit, you can do varenicline plus or minus nicotine replacement therapy or bupropion. And if they're really struggling to quit, they've already tried the first line treatment protocols, you can use biofeedback loops. So something like exhaled carbon monoxide monitoring or gamification using apps, something that shows them the results of their hard work. If the patients have recently quit and they're successfully not smoking, you want to continue pharmacotherapy for the next 3 months. And it's important to note, if a patient has attempted to quit before and is ready to try again on the USMLE, your next best step in discussion is to ask the patient, well, what kind of roadblocks do you foresee in your future attempts to quit? You want to explore their mindset. Don't try and sit there and educate them yet if you haven't explored their mindset first. It's important to note that if a patient is pregnant, bupropion and nicotine replacement therapy are safe for tobacco cessation and pregnancy, but it is not recommended to use varenicline in this circumstance. So, first line is going to be varenicline. If they're ready to quit, you can add on nicotine replacement or bupropion. But if the patient is pregnant, then do not start with varenicline. You can start with the bupropion or nicotine replacement therapy instead. 26. For alcohol use disorder, you want to look for an elevated GGT or an AST to ALT ratio greater than 2:1. The GGT is the more specific finding, however. The treatment is going to be psychotherapy plus or minus naltrexone. Naltrexone is a really interesting medication. It's an opioid receptor antagonist that reduces cravings in binge drinking, and it can be started while the patient is still actually drinking. But you would want to avoid it if the patient has a history of hepatitis or end-stage liver disease. Another option is acamprosate, which blocks the glutamate excitability receptor. If the patient is withdrawing from alcohol, this is the order of treatment protocol. You want to give thiamine, which is vitamin B1, magnesium, vitamin B12 and B9, IV fluids, plus dextrose, and then start a benzo taper as needed. So chlordiazepoxide, also known as Librium, is a long-acting benzodiazepine that used to be used more for alcohol withdrawal, but it is not used as much anymore due to the active metabolites causing a very long mechanism of action. And I always remember this because chlordiazepoxide is basically like the longest benzodiazepine name, so it has the longest mechanism of action. Instead, your next best step will be to use lorazepam, which is also known as Ativan, because it is safe for patients with liver disease, unlike chlordiazepoxide, and it doesn't have a ton of active metabolites like chlordiazepoxide does. It's important to note that for alcohol screening, the CAGE questions used to be the initial step. However, now your next best step of screening question is to ask, how many times in the last year have you had 5 or more drinks in a day? Or if it's a female patient, you want to say, how many times in the last year have you had 4 or more drinks in a day? That is your initial question, not your CAGE questionnaires anymore. That has changed in recent years on the USMLE. 28. In veterans with substance use disorder with interpersonal conflicts and new onset insomnia, what's your next best step? You should screen them for PTSD. And the treatment protocol would be cognitive behavioral therapy plus or minus an SSRI or SNRI. And then if they're having nightmares, you want to do prazosin. 29. If the patient has aggressive behavior with 8 hours of symptoms plus nystagmus, you're thinking PCP intoxication. The nystagmus really is the big clue here. And for the treatment protocol, if the patient is really aggressive and at risk of hurting themselves or others, then you would give them lorazepam. If the symptoms are really mild or they're symptoms of detachment or withdrawal and they're not overly aggressive, you would just simply put them in a low stimulation environment until the medication wore off. Number 30. If a patient over 65 years old has a fall, what's your next best step? Well, you want to discontinue mind-altering medications, avoiding polypharmacy. This is huge. Stuff such as benzos and opioids are high risk for causing elderly patients to fall. A test-taking tip for you is don't be tricked by selecting physical therapy or giving them a walker or any kind of answer like that when the history in the question stem clearly has psychotropic medications listed in elderly patients. So always go for removing the medications before you start advocating for physical therapy or rehab. Here's another test-taking tip. If you stop a short-acting benzo in these patients, such as lorazepam, watch out for withdrawal symptoms for the next 1 to 2 days. Your next best step would be diazepam or another benzo that has a little bit longer mechanism of action to help taper them down. Let's talk about some tricky opioid medications. Naloxone, also known as Narcan, it's going to reverse opioids quickly. Naltrexone is a longer-acting medication that's used to combat alcohol as well as opioid cravings, like we talked about earlier. Methylnaltrexone. This methyl group makes it too large to actually cross the patient's blood-brain barrier. Therefore, it'll just treat peripheral symptoms of opioids overdose, such as constipation. In fact, it is commonly used to reverse opioid-induced constipation due to its action on the gut mucosa without actually reversing the analgesic effect of opioids. So if they're getting unwanted side effects such as constipation, methylnaltrexone is your option. It will not cause reversal of the actual pain control that the opioids provide, but it'll help with those peripheral symptoms. Methadone. This is a long-acting oral opiate for heroin detoxification or long-term maintenance therapy. It's the drug of choice. 32. In patients with severe pain, such as a trauma patient or a postoperative patient, but they have a history of opioid addiction, what's your next best step? Well, you want to max out the non-opioid pain management options, such as NSAIDs, Tylenol, which is acetaminophen, nerve blocks, gabapentin, stuff like that. And then you can consider an opioid if they're still having pain, such as buprenorphine. This has a lower euphoria risk, and so it's less addictive potential. If the patient still requires additional pain management after doing all the above, you need to have a thorough patient discussion on the risks versus benefits of using opioids with a history of their abuse. However, failing to adequately treat a patient's pain is going to violate the ethical principle of beneficence. That's another way that they can ask you this, is what principle is violated if you don't treat a patient's pain properly? Beneficence. 33. The first-line treatment in children and adolescents with depression is going to be fluoxetine. It has the most evidence of efficacy in this age group of children and adolescents. However, antidepressants in this age group do have a black box warning of increased risk for suicidal thinking, so you have to be very cautious. You want to continue for at least 6 months after remission of depressive symptoms to decrease the risk of relapse. 34. For treatment-resistant depression with a partial response to the current SSRI, your treatment is going to be continue SSRI to keep the partial benefits and then add on an antidepressant with another mechanism of action, such as bupropion or mirtazapine or lithium or a second-gen antipsychotic, or you can even try a monotherapy with an MAOI. However, a high-yield note, a quick review here. If you're switching monotherapy to MAOI, this requires a 10 to 14-day washout period off of the SSRI at a very, very, very bare minimum, and up to 5 weeks if the patient is using fluoxetine due to the long half-life. Remember, if they're just on an MAOI and you're switching to another medication, then the washout period is 10 days. So it's a little bit longer for SSRIs. Even the shortest SSRI is going to require about a 2-week washout period. That's your safe answer on the USMLE. If it's fluoxetine, however, you want to go for a 5-week washout. It sounds oddly specific, but I have specifically seen fluoxetine tested, and you had to know that it was a 5-week washout. So MAOI is 10 days. Regular SSRIs are generally about 2 weeks, and then fluoxetine is 5 weeks. The risks of a less than 2 to 5 week washout period is serotonin syndrome, like we talked about, and this has mental status changes, autonomic dysregulation, and neuromuscular hyperactivity. Specifically, you're looking for clonus. 35. Don't get tricked by a patient with an array of depressive symptoms, such as irritability, fatigue, excessive guilt, with the chief complaint of insomnia. Don't just go for treating the insomnia. You want to treat the actual depression that's causing the insomnia. So your treatment would be an SSRI such as citalopram. Do not select the next best step as sleep education, even though insomnia is their chief complaint. You want to treat the cause rather than the symptoms.